Okay, welcome back to part B for your vector analysis EKG lecture. From our first segment, I hope that you now appreciate that those three different pictures that I showed you on the very first slide represent three different leads, and leads mean to us a stationary vector, and each of those leads provide us with their own point of view, their own perspective. Much like the different cameras at a sporting event record the same play, the same sporting play, but they each have their own perspective and help the head referee make a decision. We just went through how to use lead number 2 as our recording lead. And that means we were using it as our reference, and lead 2, of course, points down and to the left. We then compared the 5 cardiac vectors to lead number 2. The 5 cardiac vectors are shown here on this picture. Here's cardiac vector 1, 2, 3, 4, and then shown here in pink is the 5th cardiac vector, showing you ventricular repolarization. This is so important. Reading from different leads gives you different points of view about the same cardiac event, the same set of cardiac events, the repeating depolarization and repolarization. Now, what if we had a recording lead that pointed in this direction instead of right to left? It pointed from left to right. Remember, this is the patient's left and this is the patient's right. You must remember anatomical position. Again, that lead does not exist clinically, but if you have truly mastered vector analysis, I should be able to give you any recording lead oriented in any direction, and you should be able to take those 5 cardiac vectors and tell me if the pen would go up or down. That will be your task on your EKG exam, to tell me if the pen will go up or down. It will not be an acceptable answer for you to tell me baseline. Let me say that again differently. None of the cardiac vectors compared to a lead, a recording lead, a recording vector, will be perpendicular. Saying flatline or baseline will not be an acceptable answer. In your lab manual, you have a picture like this. And here we're seeing AVF, lead AVF. I'm going to go through all of the leads in just a moment. But lead AVF points straight down to the feet. So it's negative at the head and positive at the feet. This is lead AVF, its orientation. Think F for feet, meaning it's pointing to your feet. Here, I'm showing you the 5 cardiac vectors. Vector 1, vector 2, vector 3, vector 4, and vector 5, which is the same direction and orientation as vector 3. I have then drawn each of the cardiac vectors. Here's vector 1, 2, 3, 4, and 5, next to lead AVF. All you have to do is tell me if these are parallel or anti-parallel. Will the pen go up? The pen goes up if they're parallel, and the pen will go down if they're anti-parallel. Here is how I recommend you do this problem. Draw a perpendicular bisector. Let me use a different color. Draw a perpendicular bisector. When you draw a perpendicular bisector, like I've shown you here with lead AVF, it separates that lead into 4 quadrants. we recognize that back here, the tail end is negative. And that means this quadrant and this quadrant both are negative. Yet these two quadrants towards the arrowhead are positive, aren't they? So by drawing a perpendicular bisector, we have separated that lead into 4 quadrants, 2 that are negative and 2 that are positive. When you do this, you're kind of making a short-handed attempt at evaluating vectors. You don't have to draw the connecting lead as I showed you in the previous film. All you have to ask yourself is, where is this arrowhead pointing? Where is the cardiac arrowhead pointing? Clearly, this cardiac arrowhead is pointing to a positive quadrant. It is lying in a positive quadrant. If the arrowhead is laying in a positive quadrant, then you say they are parallel, and the pen would go up. Where is this arrowhead for cardiac vector 2 pointing towards? Well, extend it. This arrowhead is pointing towards a negative quadrant. It is anti-parallel, and the pen would go down. What about this arrowhead for cardiac vector number 3? Clearly it's pointing into a positive quadrant. Then you say they are parallel, and the pen goes up. What about this cardiac vector number 4? Where is that arrowhead pointing? Which quadrant? It is pointing to a negative quadrant. So that means it is anti-parallel, and the pen would go down. And then here we have cardiac vector 5. Which quadrant is it pointing to? Is it pointing to a negative, or is it pointing to a positive? And the answer is positive. So that means it's parallel, and the pen will go up. Feel free to use any of the other 4 remaining leads. We've already done lead 2 together. We've just now done lead AVF. You can do this same exercise, and in fact, in your lab manual, you're asked to pick another lead, and I have the 5 cardiac vectors already drawn for you. You just have to pick one of the 4 remaining leads that you are responsible for in your analysis, and that would be lead 1, lead 3, AVR, or AVL. And if you just give me a moment, I will go through the direction for all of those leads, all 6 that you are responsible for in your analysis in your EKG exam. There is typically in a clinical setting a 12-lead EKG. You are responsible for 6 when you analyze information on your EKG exam. The 6 you are responsible for are the 3 bipolar limb leads, leads 1, 2, and 3, and the 3 augmented, that's what the little a stands for, unipolar limb leads, and I'll explain that in just a moment. Those are leads AVR, AVL, and AVF. You are not responsible for the 6 precordial leads, though you are responsible for knowing about them. The 6 precordial leads, they give information about current moving from a posterior to an anterior approach. The other 6 leads, the bipolar and augmented limb leads, they give information about current moving from right to left, superior to inferior, your traditional X and Y axis. The precordial leads V1, V2, V3, V4, V5, and V6. They give information about the current moving from posterior to anterior, from the back of your chest out of the front of your chest. You will notice that leads V1 and V2 and a little bit for V3 have a downward deflection for part of their QRS complex, a significant downward deflection. A downward deflection, another way of saying that, downward is negative, meaning it's going below baseline, so it's negative. So a downward deflection or negative. Downward, remember, means that the precordial lead and the cardiac vector must be anti-parallel. That is why the pen is going down. So that must mean that V1, V2, and a little bit for V3 are going in an anti-parallel fashion. So let me tell you about these precordial vectors. They are giving information about current moving from the posterior, the back of your chest, to the anterior. And these precordial vectors are numbered V1, V2, V3, V4, V5, V6. And what is their orientation? Remember, this is the patient's left and this is the patient's right. Their heart is looking up at you. And you can see that V6, V5, V4, if you take your left hand and put it on your chest with your fingers sticking out anteriorly, and then take your right hand, just your thumb. Your two thumbs are pointing over towards your right arm. And your first thumb would represent V1, your second thumb would be V2, and then your pointer finger for your left hand would be V3. Those are pointing over to the right. Remember, most of your cardiac vectors are pointing down and to the left. That explains why V1, V2, and V3, if you look carefully at the pictures down here, have a downward deflection. That means negative deflection, going below baseline, anti-parallel. V1, V2, V3 pointing over towards your right arm, anteriorly over towards your right, so across your chest to the right. They are anti-parallel to most of the cardiac vectors, which point down and to the left. V4, V5, V6 on your left hand, that would be your middle finger, your ring finger, and your pinky finger. Middle finger for V4, ring finger for V5, pinky finger for V6. Those are pointing more towards the left, and that would be more parallel to your cardiac vectors, which explains why they have an upward deflection for their QRS complex. Upward deflection means positive deflection. And that means parallel. Remember your rules. We can take all 6 of the leads that you are responsible for and orient them so that they radiate outward from a central point. This is called a hexaxial diagram. Here we see lead 1. Lead 1 points from the right arm to the left, straight across the chest. Lead 2 is negative on the right arm, but positive on the left leg. Lead 3 is negative on the left arm, but positive, let's say, on the leg. What about AVR, AVL, and AVF? Well, these are not true bipolar leads. Let's take AVF, shown here. Let me highlight that in pink. Here's AVF. AVF, the augmented leads in general, they're called unipolar. And that means they only have one true positive pole. And the negative part of them, their tail end, is a hybrid, a mixture, an average of 2 separate negative poles. So for example, put your arms straight out, abduct them so that you look like you're being crucified on a cross, okay? Let's just pretend we're doing that. Your arms are straight out. And pretend that each of your electrodes on your wrists are negatively charged. Where is the average space between your 2 wrists? Did you say your head Isn't that the middle part? Isn't that the central region between your two wrists? So the machine takes an average for the negative pole. And that's why for AVF, the negative pole is roughly where your head is. It is the average between the right arm and the left arm that are both held negative. And then the feet are held as a true positive. And that's why AVF is pointing straight down. What about AVR? AVR points over your right shoulder. I'm trying to get my color. There we go. So AVR, pointing over your right shoulder. What are the two negative poles that the machine is taking an average from? Well, if AVR points over your right shoulder, then that means your left arm is being held negative. So I'm doing AVR. I'm going to highlight that now in yellow. AVR is positive, pointing over your right shoulder. That's what R stands for. So it's going over your right shoulder like suspenders. And that means your left arm is held negative, and so are your feet. And so the average distance between your feet and your left arm is somewhere in between your left foot and your left arm, if your left arm was being held out like you were being crucified on a cross, okay? And then that average pole here in space that I'm circling with the positive pole pointing over your right shoulder. I think you're getting the idea. So for lead AVL, let me get a different color. For lead AVL, it points over your left shoulder. Let me highlight that. L for left. So that is the positive side. And what is being held negative? The feet are again being held negative, and your right arm is being held negative. Where is the halfway or average distance between those two negative poles? Somewhere in between your feet and your right arm. Again, if your right arm is abducted, as if you were being put on a cross. So this is now a negative pole, an average negative pole, and it's pointing over your left shoulder. So those 6 vectors are your responsibility. Let's do it again. I'm going to put 2 vectors on each of these next 3 slides. This is the person's right, and this is the person's left. For lead 1, the right arm is held negative, the left arm is positive. Lead 1 points straight across the chest from right to left. What about lead 2? Lead 2, so this is lead 1. Lead 2 is negative at the right arm, positive at the foot. They show here the left foot, left leg. It's fine. It's just still positive at the foot. And it points down to the left. So that's lead 2. Next slide. Let's now do lead 3. Lead 3 is negative at the left arm and positive at your feet. Lead 3 points down to the right. Again, this is the patient's right and patient's left. So this is lead 3 shown here in gold. Now, what about lead AVF? In lead AVF, the foot is shown as positive, the right arm is negative, the left arm is negative, and so the machine takes the average distance between those 2 negative poles, and that would be your head. So lead AVF points straight down. For our last slide here, showing our vectors that you are responsible for, we need to cover AVR and AVL. All right, let's do AVR. Remember, this is the right and this is the left. For lead AVR, the left arm is held as negative, the leg is held as negative. The machine takes the halfway distance between those two and creates that as the negative pole. The right arm is held as positive. And if we draw our vector now, remember the tails are negative and the head is positive. We see that for lead AVR, it points over your right shoulder. What about AVL? For lead AVL, the right arm is negative, the foot is negative, and the left arm is positive. The machine again takes the average distance between the two negative poles, and now lead AVL points over your left shoulder. Those are going to be your responsibility. Now we're going to move through some of the measurements that you're expected to do in your lab manual. Please get out your lab manual and you will be able to find the sections that I'm about to go through where you're supposed to calculate things like Einthoven's law, heart rate, your segments and intervals. We're going to start working through that together. We will also do this face-to-face when we are on Zoom together. Okay, let's resume with some of the calculations that we are expected to do in your lab manual. Let us evaluate Einthoven's law. Einthoven's law states that the electrical potential of any limb lead equals the sum of the other two. We are going to use Einthoven's law to show that lead 1 plus lead 3 will equal lead 2. I'm just going to use that as my example. Please remember lead 1 is negative on the right arm, shown here as a negative RA, and positive on the left arm, shown here as a plus LA. It's not written, but we can put a plus LA. Lead 3 is negative on the left arm, shown here as the negative LA, and positive on the left leg. Now let's just add lead 1 to lead 3. When I add these together, notice that the negative LA for lead 3 cancels out the positive LA for lead 1. This leads to a positive left leg and a negative right arm. And that is the definition of lead 2. It's negative on the right arm and positive on the left leg. How can we actually prove this on a patient's EKG? Well, this brings us to our first demonstration. Here is an EKG that I posted online for you all to analyze. Here is what we do first. The first thing that I want you to do is draw your best baseline. So I'm going to start with lead 1, shown here. I'm circling lead 1. I'm using my gold color. And now I'm going to draw a best fit line for a baseline, and I'm going to draw that baseline straight through the QRS complex. Do you see what I just did? I just drew my best fit line. And by the way, all of these instructions are actually described to you in your mean electrical axis instructions, and I'll show you that in just a moment. But first step, we're drawing a best fit line through baseline. Draw baseline. Sorry for the yellow color, but I want to be consistent. Next, each of these boxes are a 5 by 5 box. 5 millimeters in height and 5 millimeters in width. So they're 5 by 5. So now I can count from my baseline to the top of my R. So here, let's count together. From my baseline, I see 1, 2, 3, 4, 5, 6, 7, 8. 8. I see 8 boxes. I see 1 full 5 millimeters. I see 2 down here, and then almost a third up there. So I have a plus deflection for my R of 8 millimeters. What about for my S? I have a negative deflection of 2 millimeters. Okay, let's do the same thing for lead 3. Here I am for lead 3. I'm drawing my best fit baseline read. That's a bit thick and it's hard to see, so let me change the thickness of my pen. So I'm going to try my best for my baseline read, going through my QRS. And here I can see an upward deflection for my R of about 1, 2, 3, maybe a +3. And then for my downward deflection, maybe a -1. -1 for my downward S deflection. So again, we draw a baseline. So 1, let me do this in a different color for instructions. 1, draw baseline. 2, count millimeters for R deflection. And 3, oops, it's not letting me write there. 3, count S deflection in millimeters. Now notice the R for lead 1, shown here in gold, is upward. And for lead 3, R also happens to be upward. It might not always be that R is upward. In fact, for extra practice, I have posted on Canvas a second EKG where you're going to see the R's are downward deflected for some of these leads, very similar to what's shown here for lead AVR. And the S is upward deflected. So going back to lead 1, we had a positive deflection for R of +8 and a negative deflection for the S of -2. For lead 3, we had a positive deflection for the R of +3 and a negative deflection for the S of -1. Now let's look at lead 2. Let's draw our best fit baseline for lead 2. Now let's count our upward R deflection. I see 1, 2, then 5 more, 7, 8, 9, 10, about 10, 10 and a half. And a downward deflection of 1, 2. So a negative deflection of 2. All right, so then let's see how close we get to Einthoven's law. We have a plus deflection for lead 1 of 8 and a plus deflection of lead 3 of +3. So that gives us approximately a +11. That is very close to our upward deflection for lead 2 of about 10.5. Now, what about our downward deflection for lead 1 is -2. For lead 3, it's maybe a -1. That's pushing it based on my baseline read. It's maybe a 0.5. And we can see that -2 plus a -1 is a -3. And for lead 2, 1, 2, let me draw my lead 2 baseline read with a thinner pen. Let's see if that helps. 1, 2, no, I still get about 2, maybe 2.5. Anyway, -2.5. If we look at the -2 for lead 1 and -1 for lead 3, that's a -3. A -2.5 is pretty close to that. So we're pretty close. And again, the trick here is drawing your best fit baseline. There's always some migration with the pen. So Einthoven's law, we're doing well if we get close in the ballpark with some of these drawings that we're analyzing online. Sometimes when we're face-to-face, students nail it. They get it exactly perfect, and that's good to see. So that's Einthoven's law. Lead 1 plus lead 3 equals lead 2. All right, now let's move on to some more calculations. You now know what the P wave represents. The P wave represents atrial depolarization. That is the electrical event. What will be the mechanical event that results? The atria will contract. And this means the last remaining 20% of blood will go into the ventricles. Please again refer to your cardiac cycle lecture to understand these electrical events leading to the mechanical events. What about the QRS complex? That represents depolarization of the ventricles. We have learned in the earlier video, it represents cardiac vectors 2, 3, and 4. Cardiac vectors 2 and 3 represent the IV septum depolarizing, with the left part of the IV septum depolarizing more quickly ahead of the right side of the IV septum. Cardiac vector 4 represents the left ventricular mass being much thicker than the right ventricular mass. What mechanical event will occur as a result of the QRS complex? The ventricles will contract, and we will start to get isovolumic contraction followed by ejection. That is ventricular systole. When we see the T wave, we know that represents ventricular repolarization. That would be cardiac vector number 5. The mechanical event that will result from that T wave is relaxation, ventricular diastole. This would be isovolumic relaxation followed by ventricular passive filling. Again, please see the cardiac cycle lecture to understand those terms. When people say that an EKG shown here in the top picture in the blue ink looks like an action potential, I understand that. It does look like an action potential, but it is not an action potential. It is a comparison of two vectors. It is a comparison of a stationary lead, recording lead vector to the cardiac vectors that are constantly moving as a result of these cardiac events. And the machine obeys simple rules. If the lead vector is parallel to the cardiac vector, the pen will go up. If they are anti-parallel, the pen will go down. If they are perpendicular, the pen will go to baseline. This is baseline right here. This is baseline right here, as is this and this. If there is no current, the pen will return to baseline. If people really want to compare the EKG to an action potential, down here in orange is an action potential from a contractile cell. And let's compare the action potential to the EKG. These black lines that just moved over are representing just guidelines to show the depolarization, phase 0, of a contractile cell depolarizing. And look, it closely approximates to the R for our EKG. And then down here, you're seeing phase 3. It's the midline for repolarization for a contractile cell. And notice that the midline, the mid-phase of phase 3, the mid-portion of phase 3, I should say, approximates the middle portion of a T wave, representing when the ventricles repolarize. If you watched your specialized and contractile cell lecture, you know that phase 2 of a contractile cell is very important. It's the plateau phase. Notice that this correlates with this part, this flat line part between the S and the T. That flat line portion is called the ST segment. And this represents when there would be calcium, activated calcium release, also known as CACR, and it would represent when the ventricles are having their maximum contraction. And let me show you this with this purple tension curve. In purple here, you're seeing where the maximum peak of ventricular force would occur. It is right in the middle of phase 2 for a contractile cell, and it is right in the middle of that ST segment. So even though, please hear me, even though on an EKG, the ST segment, this flat line that I have highlighted here, seems like nothing is going on. Actually, a lot is going on during that ST segment. We would assume, without cutting open the patient's chest, that the ventricles are generating their greatest force of contraction and ejecting the stroke volume at that time. So speaking of intervals and segments, segments are flat lines. They do not include a wave. There is a PR segment that I highlighted on the previous screen, and an ST segment that I highlighted on the previous screen. Let me highlight that for you again. So here's the ST segment between the S and the T. Here is the PR segment right here. And then there is this segment that goes between the T wave and the next subsequent P. So this is called the TP segment. An interval includes at least one wave. Shown on this picture, you're seeing several intervals. Here is the PR interval. The PR interval begins from the beginning of a P wave until you get to the Q wave. It is a time that represents atrial depolarization plus one of the two delays that I talked about in the previous video. there are two delays, one at the AV node and a second one at the bundle of His. The PR interval represents the time for the atrial depolarization and the delay of the AV node. During this time, the atria would contract as a result of the P wave. You do need to know this normal time. Anything more than 0.2 seconds. 0.2 seconds is the same as 200 milliseconds. If the PR interval takes longer than 0.2 seconds, this represents a first-degree block, which means the delay through the AV node, even though there's supposed to be a delay, the delay is taking too long. The PR segment, as I've shown you on this previous slide, right up here, is representing the delay through the AV node only. So now the question is, how do you calculate intervals and segments? Because you will be asked to do that on your EKG exam, and you're asked to do that in your lab manual. Here is the equation you use. Velocity equals change in distance over time. This is not the first time you've seen this equation. There's a reason why you had a chemistry and a metric exam at the beginning of the semester. The velocity represents the paper speed. Do not assume paper speed on your exam. We will have to give that to you. A typical paper speed is about 25 millimeters per second. Again, do not assume. In order to distract or deter from students cheating, we might give you all different paper speeds to use. Change in distance. This is where you measure in millimeters your interval or segment. You will solve for time. The correct units for an interval or a segment is in seconds. It will be your responsibility to know where you begin your measurement and where you end your measurement for your segments and intervals. You will be tested on this. Here are the intervals you are expected to know and the PR and the segments. So there is one segment missing. Here is the PR segment, which represents the delay through the AV node only. Here is the ST segment, which would be the time when we would assume the ventricles are contracting. But here's another segment you need to know, the TP segment. The TP segment is extremely important. It represents the time when all of the ventricles are at rest. It represents passive ventricular filling. But also, friends, this is the time when blood can go through the coronary arteries. This is the time when the myocardium is perfused. The TP segment is also when your heart rate goes up. The TP segment is compromised. It's shortened. What does that mean? It means the resting time for your heart is decreased. That makes sense. You're making your heart work harder. You have a faster heart rate. But it also means that the heart has less time to be perfused. Is the irony lost on you? When your heart rate goes up, your heart is working harder. Arguably, a tissue that is working harder should have more blood flow, not less. And during the TP segment, that is the only time when blood can get through the coronary arteries. Anatomy was a prereq. Figure out why. Where are the coronary arteries? They're in the coronary sulcus. Figure this out. It is only during rest that blood can flow through the coronary arteries and deliver much needed oxygen and nutrients to the cardiac cells. When your heart rate goes up and the ventricles are contracting and less time when they're relaxing, the ventricles are pushing on the coronary arteries and they obstruct them like you bending a garden hose and kinking it. That means a tissue bed is now working harder and you are delivering less oxygen and fewer nutrients. That does not make sense, does it? A tissue bed working harder should get more, not less. Our heart is definitely taking one for the team, for the entire body. When your heart rate goes up, it is getting less time for rest, delivery of oxygen and nutrients. Arguably, a reason for us to say exercising isn't healthy, isn't it? Arguably a reason to say, no, I'm just going to sit on the couch and give my heart a break. But you will learn in your cardiovascular disease lecture that working out your heart, the benefits of it when you are at rest and you're finished with your workout, your heart actually gets even more time to rest because it becomes so much better as a muscle. So more of this story to be continued in your cardiovascular problems or cardiovascular pathology lecture. So here is an example. Let's look at lead 2. Let's work, here is our P, Q, R, S, T for lead 2. Let's calculate, let's go ahead and calculate, oh, look at this. There's an extra U wave. Huh, that's a U wave. I'll explain what a U wave is in just a moment. So let's not use lead 2. Let's use lead 1 because lead 2 has this U wave, and I'm going to talk about that in just a moment. So here, let's use lead 1. Here is the P, the Q, the R, the S, the T, and here is the next P. Let's calculate the T, P segment. Again, it will be your responsibility to know where you begin your measurement and where you end. A segment is a flat line. So let's measure the distance between the T and the P wave, where the T ends and the next P begins. I'm seeing 5 millimeters, 6, 7, 8, 9. I'm seeing 9 millimeters. Come on. 9, I'm going to write it over here, 9 millimeters. Okay, so if I have 9 millimeters, my paper speed shown down here is 25. So according to the equation I showed you, 25 millimeters per second equals 9 millimeters and solve for time. So that means I'm going to time equals 9 divided by 25. And this person now has a TP segment of 9 divided by 25. We have to show proper units. 9 divided by 25 of 0.3 6 seconds. That is their TP segment. Be ready on your EKG exam to calculate the time for any of the intervals or segments that have been listed on this previous slide. Don't forget to add the TP segment to this picture as I've shown you. In your lab manual, you're expected to calculate the time in seconds for these different waves, intervals, and segments. I've just shown you how to do the TP segment. For the P wave, you're going to find a P wave for any lead you want, and you're going to measure from the beginning of the P wave to the end. And you're going to measure that in millimeters. And you will still use the same equation. Velocity equals change in distance over time. Velocity is the paper speed. The distance will be what you measured from the beginning to the end of whatever wave, complex, interval, or segment. Your job is to solve for the time. And again, it's in seconds. Down here we have some normal values for heart rate and the PR interval, QRS interval, ST segment, etc. Excuse the traffic, sorry. Amplitude. When you measure amplitude for these waves, complexes, you're going to measure the millimeters vertically. Vertical. For every millimeter, this equals 0.1 millivolts. Let me show you this here. Here's my baseline for the AVR, and here is my QRS. It's a negative deflection. So for each millimeter, so here's 5, 6, 7, 8, 9, 10. I have 10 millimeters for a negative deflection, and that 10 times 0.1 is going to tell me how many millivolts. So it's going to be 1 millivolt. Every box in vertical distance is 5 millimeters. That would be 0.5 millivolts. 2 boxes would be 1 millivolt. This is actually in your lab manual. And you can read about this as well. Okay, one of the last few things that I'm going to talk about in this video as far as for calculations is calculating heart rate. This is straight from your lab manual. You can use any lead you want. I'm going to calculate heart rate using lead 2. I'm going to measure 1 beat. I'm going to measure from one R to the other R. That's 1 cardiac cycle. I have 5, 10, 15 millimeters, 16, 17, and then over here it looks like 4 more. So that would be 21 millimeters going from R to R. And if I fill then that in here, the number of beats measured, I measured 1 beat. I had 21 millimeters for 1 beat. My paper speed, according to the picture, is 25 millimeters per second. And there are 60 seconds in a minute. And if I do all of my calculations here, I have 25 times 60 divided by 21, and I get millimeters canceling out, I get seconds canceling out, I'm left with beats per minute, beats over minute. And I have a 71 beat per minute heart rate for this individual. On your lab exam, let me say it again, you will be asked to calculate heart rate. You will be asked to calculate the time required for an interval or a segment. But also in your EKG, we will ask you to match descriptions of your P wave, your QRS complex, your T wave, your QT interval, your TP segment, your ST segment, all your intervals and segments that have been described to you, you will have to match them with your terms. That comes from this slide, slide 69, and it also comes from this slide, slide 62. Please review, and slide 60. Please be ready to match P wave, QRS complex, T wave, PR interval, PR segment, QT interval, shown here, TP segment, ST segment, PR segment. Be ready to match them with their descriptions. Another matching section you should be ready for is matching cardiac arrhythmias and electrolyte imbalances. We will take the descriptions straight from these following slides. Tachycardia is an abnormally fast resting heart rate. This is usually described as more than 100 beats per minute at rest. Bradycardia is an abnormally slow resting heart rate, less than 60 beats per minute. Incomplete AV nodal block, a prolonged PR interval. Remember, first degree means it takes longer than 0.2 seconds, greater than 0.2 seconds. That means the delay through the AV node is taking too long. This invites the heart to then enter into electrical and mechanical events that are not in syncytium, not coordinated. It can lead to fibrillation, which means a complete lack of coordination. In fibrillation, the heart is contracting. It's quivering. That's what it looks like if you could actually open a patient's chest. The muscle is contracting, but not in a coordinated fashion, which means you're not getting proper blood entering, going from the atria to the ventricles and out of the heart into the arteries in a coordinated fashion. And that means most certainly blood flow to tissue beds of the body is now compromised. A complete AV nodal block means that we have complete dissociation between the electrical events of the atria versus the ventricles. And that's shown up here in this top picture. You're seeing P wave after P wave after P wave, and then finally you see a QRST. And I'll remind you, the QRST represents electrical events in the ventricles. So that would be a complete AV nodal block. We are not getting the electrical events going through the bundle of His past the AV node. The AV node is blocking the transmission of the electrical events. And if you have watched your specialized and contractile cell lecture, you know that the bundle of His, the right and left bundle branch, and the Purkinje fibers can fire their own action potential. They just take longer to reach threshold. The last two slides I'm going to do for this portion of the video deal with electrolyte imbalance. Again, this will be a matching portion of your EKG exam. Your answer choices will be one of the 6 electrolyte imbalances. Here we have hypernatremia. Emia means in the blood, which is an extracellular fluid. So hypernatremia means you have too much sodium in the plasma. What will this do? It will not allow as much calcium to enter the cells. Less calcium means we don't get as much contraction, and the heart will become weak as a pump. It will have negative inotropy. Hypercalcemia, more calcium in the plasma. We will have increased calcium-activated calcium release, and that means a greater inotropy. That's what this plus means here. But we will have a reduced heart rate. Why is that? Because of the baroreceptor reflex arc. And the baroreceptor reflex arc is discussed in your vessels and hemodynamics lecture. More contraction leads to more stroke volume, would lead to more action potentials from the baroreceptors up to the medulla oblongata through cranial nerve 9 and 10. The medulla oblongata, in compensation, would have a reduced output toward the effectors of the heart, meaning the heart would become less strong as a pump, would become less active as a pump, so heart rate would go down, and that's what we see here with a negative sign. With hyperkalemia, we would see very pronounced peaked T waves. Hyperkalemia, more potassium in the plasma than normal. Normal is 3 to 5 milliequivalents. Hyperkalemia is when you start to get into 6, 7, 8 milliequivalents of potassium in the plasma. It is life-threatening, and we would see this on the EKG as peaked T waves. The last video for this section is the hypos. Reduced sodium in the plasma, reduced calcium in the plasma, reduced potassium in the plasma. For hyponatremia, reduced sodium, we would see a depolarization delay. And that means we would have a decreased chronotropy, decreased heart rate. With hypocalcemia, we would have reduced calcium-activated calcium release. And this would lead to a weak heart as a pump, reduced inotropy, shown here as this negative sign. And if the heart is not as vigorous as a pump, then there would be less stroke volume, less action potential sent from cranial nerves 9 and 10 from the baroreceptors up to the medulla. As a result, the medulla would increase the pump rate of the heart. The chronotropy would go up to try and compensate for a reduced stroke volume. That's what we see here as the plus. And then hypokalemia, we see the U wave. Now, interestingly, when I was looking at lead 2 here, and I was saying to you, this is the P, this is the Q, this is the R, this is the S, this is the T, and look at this little wave right here. That's a U wave. Why is it called a U wave? Students say, well, it doesn't look like a U, it's going up, not down like a U. Well, U is the letter after T, so that's why they're calling it a U wave. So isn't it interesting that on that EKG, looking at lead 2, we see this U wave in the patient. We saw that. That's it. That's pretty cool. I didn't even mean to get that. So U waves for hypokalemia, a reduced heart rate, negative chronotropy, and a U wave. Well, that concludes part B for our EKG analysis. There will be one more video that deals with calculating mean electrical axis.